Dr. Geoff Knight. Geoff, you're going to share with us some of your experience in Australia.
Important that the pharmacological management of caries has become, apart from the, I suppose, the digitally inspired amputation of teeth that so many of our colleagues get involved with. And I'm very honoured to be part of this program. Have the next slide, please. Managing caries, basically, it makes it available to so many vulnerable people. Someone goes into emergency ward with a high caries rate, they can be triaged, and certainly the caries, if they wish, of course, can be deactivated by the use of an application of Silver Diamine Fluoride, so they can leave that emergency room without any caries. And I think that's such a wonderful thing, because so many people, certainly here in Australia, they get on this bandwagon where they're in and out, there's long waiting lists, and all they ever get is emergency care. We have the next slide, please. The other thing, it introduces wonderful efficiencies in managing caries that you really can't do in a normal dental practice. First thing, it reduces the waiting time, because there's really very little need to do any sort of tooth preparation, and that's a very significant fact when certainly then here in Australia that the health system is under tremendous stress, or the public health system is under tremendous stress dealing with caries. And of course, it dramatically reduces the need for general anaesthetics in young children. This is one of the really sad things that goes on, because these kids that can't be treated, they're sort of funneled off to a general anaesthetic, which certainly can't be good for a 4-year-old or any child. And by just explaining to these children that what's going to happen using minimally invasive techniques, it's wonderful to be able to take children off the general anaesthetic list, and of course it saves the government a lot of money as well. And the final sort of benefit is this it's a simple treatment protocols, and this facilitates providing care in remote locations, and I don't mean overseas, but remote locations in nursing homes away from the dental office, and in schools where dentists can go in and triage these children on site, and again expand their delivery of dental care and reduction of caries at a significant rate. We have the next slide, please. This is an unpublished study out of the University of Melbourne, and it was Dr. Rani Yahweh of the Dental Health Service Victoria put this together, and it's a study on 4-year-old children, many of whom were prescribed a general anaesthetic. And so there were a total of 114 children, and half boys and girls. 12 were put down for a general anaesthetic. It was a combination of SDF application as an adjunct to twice daily brushing with the fluoride toothpaste, and also comprehensive diet counselling. And the 6-month results are really very encouraging. Firstly, there was a 78% reduction in active caries, and that goes along with what other studies are finding about an 80% reduction in caries. 99% of the general anaesthetics were avoided. Only one child on the GA list needed an anaesthetic, but the children in that group may have well needed an anaesthetic as well. So it's this dramatic reduction in general anaesthetics for children, which is so good. There was an increase in the OHIP score, which I believe is a self-reported quality of life. I'm not quite sure how 4-year-olds manage that, but that's still, kids feel better about themselves. And the other thing, of course, is, as Dr. Chu said, very high parental acceptance. The parents of this program are very pleased to have their children involved in this type of care. Have the next slide, please. Okay, this is a study, again unpublished, that's going through the system. It's done in the Dental Health Services of Tasmania, and the aim of the study was twofold. Firstly, to compare the 3 monthly treatments of sodium fluoride varnish against the one-off annual treatment of SDF, and the other aim was to compare the cost effectiveness of SDF against standard dental care. And they were children 8 years or less with asymptomatic caries, and they were randomly chosen through the system. Now, the study was disrupted by having to stop the fluoride varnish, as it was significantly inferior to SDF, and they thought there was ethical constraints in continuing with this study if the SDF was so effective. And the other thing is that the treatment cost of FGF was dramatic reduction in treatment. It's similar to Rick's study. The cost of doing a restoration per child was 27 Australian dollars. But the cost of standard treatment per child, again, these results are skewed because you've got a situation where there are other things happening with the children, but you can see the difference of about nearly $1,500 against the cost of $163 to treat a child. So there's huge economic benefits as well as the benefits to the children as well with this type of treatment. And the outcome of this is that SDF is now used in every government clinic in Tasmania. It was started off in just the area around Hobart, and once they saw how effective it was then expanded to every clinic. Can we have the next slide, please? Okay, so where do we go from here? Where's this story? Where's this journey taking us? Well, there's a number of issues I'd like to talk about. The first thing is toxicity. A lot of colleagues I've heard say, "Oh, that's very 38% silver fluoride. That's very toxic. You shouldn't be using that in children." But there have been a number of studies that have shown that. I think there's one on the short-term serum pharmacokinetics of one-off treatment of silver diamine fluoride was that it was well below the US EPA reference dose. And they said the silver was slightly higher, but you'd need a lifetime application of silver to become really toxic. So I think it's been well and truly put to bed. I've certainly seen no adverse signs, but I've been using the material now for nearly 20 years. And it also supported by the studies that have been done looking at this. The eschar that formed, quite a high pH of SDF can burn gingival tissues. And I had a dentist come up to me at a seminar once and said, "I'm not using this material anymore." The whole palate went white. And I said, "What were you applying it with?" And he said, "I was using an eyedropper." So obviously, you apply it to where the caries are. You only need a very small amount. You dab it on the caries with a microbrush, and that's it. And keep it away from the gingival tissues. But if you do get a caustic burn, you get a white eschar that forms, and certainly a couple of hours later, the escar's gone. And I've never had any problems with children that have come back with ongoing issues with application of silver fluoride. Fluorosis, there certainly be concerned that the inadvertent ingestion of high dose of SDF can cause fluorosis. And there was a study done in Western Australia, which apart from showing how good it was, this was suggested that the dose was so high that it could cause fluorosis in children. And as a result of this, the Western Australian government, who was using it very happily in their dental clinics, stopped using it. So I think now that I've sort of done a look on PubMed and Medline, and there's certainly, I can't find any published stories on published data on fluorosis with silver diamine fluoride. The other issue is the 80% effectiveness. I think we need to look for the penicillin type effect, something that we can apply, and we can increase it to the effectiveness. So certainly, you never get 100%, of course, but certainly something above 80%. Say with an annual or biannual application, and make the material more effective. And the final thing that I think we should be looking at is sustaining. That currently, the SDF application is limited to the public health system, deciduous teeth, and geriatric root caries or clinics or geriatric clinics, and it's therefore there's no application for this into the general area of general dentistry. So that's something else I think we should be looking at. Can we have the next slide, please? Okay, so I think the aim of the whole thing is to what I'd like to see is bring SDF into mainstream dental care across all parameters of dentistry, because I think that the pharmacological management of caries is just so much more important and makes so much more insensitive than the antithesis of the amputation model that so many of our colleagues are pursuing. So thank you for Raman for that opportunity to speak.
Good, Geoff, thank you very much for that. I suppose one of these studies, the alarming studies of reduction in general anaesthetic, is seeing the child early enough. because silver diamine fluoride is going to arrest the decay and stop the progression that will then lead to sepsis and pulpal involvement, etc. So the critical thing is seeing the child early rather than seeing a child that's presenting with abscesses or with pain. How did the Australia experience manage to get children early enough for them to come and have this treatment?
Well, that's the important question, of course, because the issue is that if you have a symptomatic lesion, silver diamine fluoride is not successful. I've used it sort of with trepidation over a number of cases over the years. Sometimes it doesn't, and of course, if it doesn't work, it's the silver diamine fluoride that causes the problem. I think it's only a matter of education and getting kids into the dentist as quickly as possible. It's an education system. We need government a government sort of dental health education program. Dental Health Week, the Dental Association does what it can, but I think that what we really need to do is get these kids in as early as possible so we can prevent the problem before it becomes symptomatic, and therefore you need other more drastic measures to treat it.
And I think that's one of the encouraging things of an integrated healthcare approach, because children are turning up to general medical practices for vaccinations, and early referral would be very useful when they're detected there. And the second, I like the idea of the dental vaccination. Parents identify with vaccinations of early children and come and have a tooth treated and managed and strengthened is in every aspect could be sold as a dental vaccination. But Geoff, just finally, how do you think the effectiveness of SDF can be improved?
Well, I've been using this in general practice, but also out in the field in East Timor and Papua New Guinea. And I found that the prior application of phosphoric acid beforehand, no one seems to be using phosphoric acid, but it's a wonderful way of cleaning a lesion. It opens up the dentinal tubules, and it dissolves the tooth mineral and exposes the protein, which again allows the silver diamine fluoride to actually sort of attach to the caries dentine, which is actually infected with bacteria. So before I use this material now, I tend to use a slightly longer etching time, and I find that very effective. And it surprises me really why no one else appears to be using an application of phosphoric acid before the silver diamine fluoride.